All right. Hi, everyone. I'm actually so excited to chat with Dr. Megan Crawford, a PhD, SLP, a medical speech language pathologist, and a researcher specializing in swallowing disorders, particularly dysphagia management in hospitalized patients. Um, I would add this that you really like working with critical care and acute stroke patients. And Dr. Crawford is widely recognized for her interdisciplinary clinical research and her work bridging the gap between swallowing science, imaging, and patient outcomes. She also previously worked as an acute care speech pathologist at VCU Health and Bon Secours Health System in Richmond, Virginia, and also at Norfolk General before transitioning into full time research as a research associate at the University of South Carolina. And Dr. Heather Benia is with you over there, and you guys
Yeah,
work closely.
yeah. So I've been part-time doing the research associate and then part-time still continuing my clinical practice at the hospital.
I love that. That's the best combination.
It's been great. It's been great.
Nice. And then also, I would say your interests are heavily focused on airway protection, swallowing imaging utilization, and dysphagia management during acute stroke hospitalization. I mentioned a part of that. Um, Dr. Crawford earned her PhD in health-related sciences from Virginia Commonwealth University, becoming the first speech language pathologist to graduate from the doctoral program.
Thank
Congratulations!
you very much. I was very grateful for for the opportunity. VCU itself does not have a speech pathology program, but I was really grateful that they were willing to work with me and take a chance on me. And then in order to have some dysphagia mentorship, I reached out to Katrina Steele. Out of the blue, never met her before. I just know I had read all of her like articles. And so I had reached out to her and just was like, hi, this is my dissertation. Would you be on my committee? Thinking it was a shot in the dark. But anyone who knows Katrina knows that I picked one of the best people because she emailed me back within probably a half an hour. It's like, sounds intriguing. Let's talk about that. So that was really great that I was then able to have like an interdisciplinary dissertation committee as well.
That's amazing. Beautiful. I was just going to get to that. That
Sorry.
your that your dissertation focused on clinical decision making, swallowing imaging, and patient outcome during acute stroke hospitalization. And she continues to contribute actively to the advancement of dysphagia care and clinical education through her involvement with the Dysphagia Research Society. Uh, so happy to have you again.
Yeah, thank you. No, it's so wonderful. I know we it was so lovely to meet you at the DRS conference back in March, and so I'm so glad that we could connect.
Great. Thank you. All right, let's see. So, acute stroke, that's one of my most favorite patient population. It's just, during the spontaneous recovery phase, you get to see so much. You can do more than dysphagia.
Yeah.
My own thesis, my own capstone was on this, so I love it.
Yes, I know because you and I really like hit it off with talking about that at DRS as well, which is great. So
So let's see. In acute stroke care, what are some of the most important factors clinicians should consider when making decisions about swallowing imaging?
yeah, that's a great question. I think that there's a lot of considerations because of course our field is very diverse and has a lot of components to it. But my biggest takeaway for I would say is one of the most important factors is that swallowing imaging in acute stroke should be treated as clinically necessary and not optional or just nice to have. Post-stroke patients are, as we know, at very high risk for dysphagia, including silent aspiration. And that risk is especially complicated by, the sensory changes, the cognitive changes, communication, fluctuating alertness, and then also just the dynamic nature of early neurologic recovery. We can see a patient that, one day looks a certain way and then looks a completely different way the next. And, of course, we know that our bedside clinical swallow evaluations are important. Of course, we've spent a lot of time working with that, and we've, made it more comprehensive, but it just cannot reliably tell us a lot of things about swallowing, but especially, for these patients who are silently aspirating. And it also can't tell us what is the actual underlying physiologic impairment and whether there's a strategy that's actually changing the mechanism of the swallow. So kind of like one of the most important factors for me is I always think about whether or not I have enough information to make a recommendation for a patient that is defensible and also patient-centered. If the recommendation involves restricting oral intake, keeping someone NPO, modifying liquids, delaying oral intake, talking about a G tube, a long-term feeding tube, then I need to ask whether I'm making that decision from actual swallow physiology or just from indirect signs and best guesses. Because we wouldn't expect other disciplines to make medical decisions without clinically necessary imaging when imaging is needed. We even know this too with physical therapists. They're going to ask for imaging before they start, focusing on a certain area, because what if there's they might think it's muscular, but maybe there's a fracture in the bone that, that would make it worse. So, that is kind of seen as yeah, that makes sense. But in dysphagia care, we as a speech language pathologists are often asked to make these high stakes recommendations about food and drink and quality of life without adequate access to swallowing imaging. So instead of just, swallowing imaging just being a nice to have, we need to name it what it is, which is an access and also an ethical issue and not just a workflow inconvenience. Because we need to be precise about what questions we are trying to answer and what modality can answer it. Of course, we know FEES and video fluoroscopy can overlap in really important ways because they can both guide oral intake recommendations, but we know they're not interchangeable at the same time, right? And so FEES, super valuable for a lot of things like secretion management and visualization of the larynx and pharynx, fatigue, bedside access for our medically fragile patients. And I feel like that's a big area where I use FEES is in, our critical care ICU settings where it is, it'd be maybe dangerous to take them to a fluoroscopy suite. Whereas with video fluoroscopy, that's uniquely valuable when the clinical question is about the underlying biomechanics of the swallow across oropharyngeal and cervical esophageal phases. So looking at the bolus flow, the timing, the hyolaryngeal excursion, the epiglottic movement, all of those things and how those specific physiologic impairments contribute to aspiration or residue. So if we're trying to design rehabilitation and not just choose an oral intake modification, we do need to understand what's going on physiologically. And I think that distinction is especially critical because, again, we're at this very early stage in acute care with strokes. And instead of thinking about modifying oral intake as like, okay, I've modified it, I'm done. It should be seen as a temporary support that lets patients eat and drink as safely and efficiently as possible while we are pursuing their recovery. It's not an endpoint of dysphagia care. Endpoint's not, okay, thin or thick or PO or NPO. The endpoint is understanding what is the impairment, targeting that rehabilitation appropriately, supporting nutrition, hydration, and then preserving dignity and participation of our patients while we are reassessing changes as the patient dynamically evolves. And really that dynamic nature of acute stroke is really important because, again, like I said earlier, the swallow we see on Mondays, maybe not the same swallow we see on Wednesday. So that does not mean we should be making these permanent feeding decisions from a single snapshot. It means that swallowing imaging may need to happen more than once throughout the recovery trajectory, or especially when our patients have a change in neurostatus. And because really what has been so, it's been a really eye-opening thing for me that as I've been working with Dr. Benia and, also working with Dr. Kreckler and Dr. Wilmskotter, like they're all looking a lot at these downstream effects of acute care stroke. And they talk a lot about how acute stroke clinicians, we don't get the feedback on how our decisions impact the trajectory as much. And so what ends up happening is that we're being asked, hey, I need to get this patient discharged. They're not allowed, they're saying that they can't take a patient with a short-term feeding tube. So we need to either get the meeting or get them a long-term feeding tube. And that might be like the hospital day 5. That is so early in their recovery and their trajectory. But then it's like we're kind of put in an impossible decision, impossible position. And then, okay, so maybe they get a long-term feeding tube and then they discharge, and the next people say, oh, they have chronic dysphagia. They have a chronic need for a G tube. It's, so we're not going to touch it. And so that's actually another thing that was so eye-opening, that I have begun now my patients with feeding tubes, if they come to the hospital and they are, stable enough, I don't want to, do it when they're not stable. I always try to re-image them. Since I know that I personally at my hospitals have had good access to imaging. And so it's like, if that's a barrier to not have access, I will go ahead and take out one of those components of it because I have the access.
That's beautiful. I was just going to talk about that, the instrumental necessity and the need of it. And a really good point that you made about fees. Also, it's the repeatability and how easily you can access this. You can just like kind of just get your scope in there. You don't
Yeah.
have to really talk to radiologists or
Right.
radio technicians. Oh Lord. And then, oh, we have just inpatient this slot available. I'm sorry, we can, it's a lot of dependency that we can, a lot of other variables that come into versus fees. You're the person ready to go, patient
Yes.
is there, get it done. And also you can see, as the organic deficits, the changes that's happening within 2 or 3 days post stroke.
Right.
It's a totally new, a totally different picture that you're working with.
Yeah, yeah, and it really does. And I mean, that's where I think that, understanding that both of those imaging modalities are so important. They're not just, one or the other.
Nice. That puts me on to another good question about how do you balance clinical bedside judgments with instrumental assessments like fees or VFSs in dysphagia management?
Yeah, that's a great question. And I really don't see bedside judgment and swallowing imaging as competitors. I think they're complementary to each other. I see them as different sources of information that all need to be integrated. Because a strong bedside evaluation gives us really essential information about alertness, cognition, our cranial nerve findings, positioning, endurance, secretion concerns, voice, things like that, and how the patient's actually just functioning in this actual hospital environment. But of course, as we've talked about, bedside judgment has its limits, especially if we're talking about an acute stroke. And so I think that they both serve a purpose, but can't tell us absolutely everything on their own. So I feel like the balance for me starts with what is the clinical question that I'm asking. So if the question's, is this patient alert enough to participate, or can they maintain positioning, or what's nursing seeing during meals, then the bedside is giving us crucial information on that. But if the question is the patient aspirating silently? Is residue driving airway invasion after the swallow? Is the problem that I think is occurring, is it airway closure? Is it, oropharyngeal excursion? Is it sensation, And then also what exercise or strategy actually targets the impairment? Then we need imaging. And we should base, fees or video fluoroscopy based on the patient, the clinical question, and, what it shouldn't be. And of course, we know that we're in this environment, but we really need to kind of get away from the idea of like, just this test is the easiest one to do, so I'm going to grab it. And I think I'm absolutely guilty of that, because it's like, I like you said, like with fees, yeah, I can just like pop on over, with my scope and hello. But it was actually interesting because I knew we were talking about this, and I actually had a patient that came in for a modified barium or a video fluoroscopy this week. And the patient said, I was told to tuck my chin when I swallow. And
I
I
love that point.
yeah,
Yes.
and I said, okay, did they tell you to do that? And it was like, no, it was my family member who's an occupational therapist, and no shade to occupational therapy, but she had read somewhere that that's helpful to the swallow. And so, I think that that's even an interesting point too, that I'm not, going to immediately be like, well, chin tucks, you should be doing that, without imaging. We know that that's the case. But I said, okay, well, let's see if that actually helps you, literally this patient takes the chin down and it just pours into the airway, So I said, hey, so actually that's not the way to go for you. I said, it can help some people. But that's again why we need that imaging before we're going to say, yes, do this strategy. And part of that with like the, ease of, access to it, we need to be really careful not to let these system barriers masquerade as our clinical reasoning. And I think that, if a patient needs swallowing imaging and the system can't provide it, it's not the same thing as the patient not needing imaging. We can make the best possible decision or best decision possible with the information we have at the moment, but we need to be very transparent and honest about what we still don't know with that. There's a difference between saying, yes, I have enough physiologic information to make this plan, versus I'm making this safest temporary plan that I can because I do not have the ability to complete imaging. And we need to differentiate that clinically, but also ethically and for advocacy for our patients. And there are definitely times that, I'll have a patient that it would be extremely dangerous for them and us to do swallowing imaging maybe, and maybe they had a prolonged intubation and, I would normally want to image them, but is it weighing risks and benefits?
That's
Do we just, and I will say, while this patient has these risk factors and I, would like to image them at this point, benefits outweigh the risks of cautious initiation of something, and so I think that, trying to think in competing risks rather than just one risk at a time, so, imaging, of course, is important, and our aspiration risk is really important, but so is dehydration, so is malnutrition, so is medication access, so is rehabilitation participation. So if an oral intake modification that reduces visible aspiration during swallowing imaging may still fail the patient if they're not drinking anything and can't maintain their nutrition and hydration, our NPO orders may reduce our oral bolus aspiration, but of course we know it does not eliminate the aspiration risk and can create other harms in a lot of ways, but especially if it's not paired with that aggressive oral care nutrition planning. And so really restriction shouldn't be treated as the same thing as safety. So from my standpoint, the best use of imaging for acute care, but also in general, is not to just decide what someone is allowed to eat and drink that day only.
I love that.
Yeah,
Yes.
thank you. So it's to understand, what the patient needs next. Do they need a compensatory strategy? Do they need a specific exercise program? Do they need secretion management report or support? Do they need repeat assessment consistently because their swallow is changing? So the imaging results should really move us toward a more precise plan and not just a more restrictive label. And I think that's where collaboration is really important, in general, but also especially in acute care. But, that keeps that plan honest after we evaluate the patient and come up with a plan. Nursing may tell us, patient takes 2 sips and then they're done. They will not have anything else. Respiratory therapy may say, hey, their secretion burden or their oxygen needs are worsening. And even though you said they didn't aspirate, we're seeing these signs and, there's these concerns. Dietitians may say, hey, the intake is nowhere near adequate right now. And then neurology may help us with the, stroke trajectory. And then families may tell us, what would the patient actually do at home? And so while the imaging suite gives us the physiology, the team helps us understand whether the plan works across the other 23 hours of the day. So I think that that's important because precision doesn't always mean more restriction. It might mean that we're giving our patients back some oral intake that they can manage in the safest way possible, or using a temporary restriction while we rehabilitate. So I think that's a really important consideration. It's a way that my practice has changed over the last 10 years, especially, is that I would, always, well, you having this aspiration and you need to be doing these things. And, I think that now
This
I joke with my patients, but I say, and I'm not a nautical person, so I hope I'm using the correct terms, but this is what I say to my patients. I say, you're the captain of this ship. I am the skipper. I
oh
give you a status report. I give you the information, as objectively as I can, and um, give you the risks, give you the benefits, but ultimately it's up to you. And then I'll say, if family or caregivers there, you're your co-captain. I give you that information, and then you take that and proceed accordingly.
that also includes, things with accepted risks or the dietary. I absolutely like that. I might start that with my patients too.
I
You're the captain, yeah.
yeah,
And send
I'm
to the
like very
person.
weird with my, like, I don't know, like, I don't know what is that, like analogies or whatever that is, but
Great
uh,
analogy.
thank you. Well, I try to, too, I think part of our education too in acute care is like they are getting so much information that I try to at least give them the information in a way that maybe is memorable in a certain way. And I do try to write it down and things too. But I think that trying to get a little brain, you know, reminder in there is good.
No, they'll associate that with like, okay, I heard that from my speech language pathologist at the hospital and that. And you know what, Dr. Crawford, I really liked one of the most important most important like point that you brought up because I know imaging is so important. I know instrumental evaluations are so important. But as you mentioned, we're just seeing a snippet. We're just seeing like, okay, 2 to 3 trials of teaspoons, then you progress to cup sips, successive cup sips. But we are not seeing in a whole, the holistic picture, the whole picture as to bedside, if the patient has enough endurance, if the patient is really liking what they like or the food they prefer. So, having all those pieces together and obviously having the physiological deficits and aspect of imaging and instrumental that really adds to it is it's a beautiful way to coming up with a good clinically sound decision making in terms of the diet textures.
Absolutely. I think that's great. And I think that that's a very, very good point there.
That puts me actually on to another question. What are some misconceptions about the airway protection and aspiration risk in post-stroke patients?
Yeah, that's a great question. I think probably one of the major misconceptions is probably any, people who know strokes, it probably is one of the more obvious ones, but it's that coughing does not tell us everything. Coughing is not our major indicator of, you know, aspiration necessarily. If the patient coughs during these, PO trials, it's obviously a very important observation to note, but it also doesn't automatically mean that they aspirated. It could reflect, residue, poor timing, secretions, reflux, or something else entirely. I remember one time I did a fees on a patient, and every single time this patient swallowed, and I was just not convinced, but that it was aspiration. But of course, if I cannot give a defensible answer here without imaging, so I went ahead and did the fees, and this patient had a pretty large protuberance on her epiglottis.
Oh my
And
God.
so what I kind of postulated, and I think what it was that epiglottis would invert the protuberance. I think it might have been a cyst, but I don't exactly remember. But that protuberance that was on there, I think, was hitting the posterior pharyngeal wall. And it was giving her that sensation of like, something's in there. And it was making her clear her throat because, as far as I could tell, she had no airway infiltration.
Wow.
So I think that, that's an important thing, that cough does not equal aspiration, but the reverse is also really important. If a patient does not cough, it does not mean that they are safe, especially for our patients with strokes. Silent aspiration is very real in these patients with strokes, especially when, we have sensory systems, cognition and communication are affected. it's just one reason why, again, imaging is so critical with this, population. And then too, going into aspiration pneumonia, I think one of the big things is that, everyone, outside of, people who specialize in dysphagia, oh, aspiration is pneumonia develops because someone aspirated food and drink. Like, no question there. We know that aspiration is, of course, important, but pneumonia risk is much more complex than that. Oral bacterial load, they did such a great panel at DRS this year, with Dr. Puglia and Dr. Ashford and blanking, I'm so sorry, I'm blanking on the other researcher that was on there, but they did such a great panel on that. But, talking about oral bacterial load, dependence for feeding, dependence for these oral cares, these medical comorbidities, respiratory reserve, all of these things are important considerations because two patients may show similar airway invasion on imaging, but their pneumonia risk might be super different depending on their oral health, their mobility, things like that. And that's why, our team-based management are not side issues. They are part of this airway protection. And then from there, with the imaging, is that, well, maybe not the imaging, but the airway protection is that, restricting does not automatically mean that something is safe. And I kind of think that the overarching kind of umbrella of that is that biggest misconception is that dysphagia management is binary. It's one or the other. It's is not necessarily, really does it oversimplifies it. It's real dysphagia care is much more nuanced than these binary things. These oral intake restrictions and compensatory strategies are tools. They are not our destinations here. So we should always be thinking, especially in acute strokes, these trajectories, because the swallow may change rapidly and the decisions that we make might not be the decisions we make the following day.
It's the overall, yes, absolutely, definitely. And also, yeah, stroke patients every day is a new day, I feel, for them.
Yes.
So you have to really kind of work with it. Your follow-ups also would look totally different than one day, or, they would get a TPN, they would get a good IV, and the next day they're hydrated and they're up and running and they're
Yes.
perky. And I'm like, what just happened yesterday?
Yeah.
So
I know. It's
it's truly
wild. It's truly wild.
yeah. With that being said, we talked a lot about the clinical and it was great pointers and it was really amazing to see. But I would like to talk more about the research perspective. Where do you think the field of dysphagia management is heading for over the next 5, 10 years? But also before that, I would love for our audience to know more about your research.
Oh, sure. Yeah. So, my research right now has been a lot of supportive measures there on different projects. So, I've been working on looking at with Dr. Benia and Dr. Kreckler, looking at, feeding tube, in nutrition and placement of the feeding tube with swallowing deficits, hydration, and then also just too with patients with dysphagia, the nutritional, makeup of what people who have dysphagia are eating and drinking. So those have been really, really fascinating areas that we've been looking into there, which is really, really important and really helpful. And then I've also been working with Dr. Steele and a big team of people on looking at literature with the International Dysphagia Diet Standardization Initiative as well. And then I will be actually going and starting a research fellowship soon with UW-Madison.
Yeah.
It's a partnership between them and the VA with Dr. Michael Puglia and Dr. Nicole Rogas Puglia. And I'm hoping to look at more of the bacteria microbiomes with aspiration pneumonia, especially in
Wow.
critical care medicine.
critical care medicine. Congratulations.
Yeah, thank
That's
you.
lovely.
Thank
Yes.
you.
We need more research specifically in, aspiration pneumonia
Yes,
or say for patients with post-stroke.
yes,
Because,
definitely.
yeah, because like aspiration it can just happen. It doesn't have to. And more so, actually, I would say pneumonia. You
Yes,
can really aspirate on your own secretion, despite a patient being NPO. There's so many,
right.
factors and variables that can aid to it.
Yeah, and like post-stroke, or a post-stroke pneumonia,
Post-stroke
or
pneumonia.
stroke, stroke related. How much of that is aspiration versus other mechanisms? We just don't really. I don't. I think there's just a lot to learn about the actual makeups of the different kinds of aspiration-related pulmonary illness, and I think it's important for us to delineate that a little bit.
I'm glad your research sounds really amazing.
Thank you. Thank you.
So with dysphagia management, this is where Dr. Crawford is headed. And also, what advice would you give to newer SLPs who are interested in pursuing both acute care practices as well as research in dysphagia?
Yeah, that's really a great question. Um, for acute care dysphagia and dysphagia research, they're both too complex to do well in isolation. Some advice that, think about is to find people who challenge your thinking. Find people to help you refine your research questions or your clinical questions and how to modeling how to stay clinically grounded while doing rigorous science. That includes SLP mentors, but also physicians, nurses, think that really, understanding that patients are part of this as well. I think that the best research questions often come from the space between disciplines. From a clinical standpoint, I would tell newer SLPs to become medically fluent. Not because we're trying to be physicians, medical physicians, but because swallowing decisions are medical decisions. You cannot separate dysphagia.
Okay. That puts me on to my another question. From both a clinical and research perspective, where do you think the field of dysphagia management is headed for the next 5 to 10 years?
That's a great question. So I think that the field, it's really amazing seeing how much the field has evolved even in the 10 years of me practicing clinically. But I think that the field is moving towards more precise, medically integrated, and physiology driven dysphagia care. Clinically, it means that we need to move beyond asking only, can this patient have thin liquids? Do they need thick liquids? And towards asking, what is the impairment? What mechanism is driving the risk? Is this primarily an airway closure problem, a timing problem, all of the above? These are all different problems and they should not all lead to the same recommendations. And that's where the neuroscience of swallowing is becoming really, really exciting. So your work by Yanina Wilms-Cutter and Heather Benia and others have really pushed the field, especially as it comes to post-acute, post-stroke acute dysphagia management, is that they've been pushing it to think about the swallowing as a distributed network rather than a function controlled by one isolated swallowing center. And I really liked that Yanina presented at DRS and used this analogy of an airport hub.
Yes.
That some brain regions and connections may function like these major airport hubs. And if a smaller route is disrupted, the system may reroute to go somewhere else. But if a major hub or a connection point is affected, this disruption can ripple across the network. And I think that framework kind of helps us understand why lesion location alone may not fully capture that, post-stroke dysphagia risk. And so we need to understand kind of how stroke disrupts this broader swallowing network and how that disruption shows up physiologically. And I think too that, looking at health services and implementation research will be really essential. We need to ask, who gets the swallowing imaging, who doesn't, who gets oral intakes modifications without imaging, who is NPO without follow-up, who receives these timely assessments, and how does access differ across hospitals, especially with weekend staffing models, productivity requirements, things like that. And we also need to study how dysphagia decisions travel after acute care. So that's kind of what I was talking about earlier with, learning about these, trajectories of these patients that are getting a feeding tube placed in acute care and never have follow-up, and they have it, for life. And that's really, I think that focusing on that is extremely important. It's a systems problem. It's not just a clinical problem. So I think that some systems research is going to be very needed for this. And I think advocacy is going to be a really major part of the next phase of the field. Yes, and we need to push back on these ethics of making these critical medical decisions about food and drink and medication access without sufficient access to swallowing imaging. And if we believe that dysphagia care affects pneumonia risk, nutrition, hydration, all of these things that we know it does, then we have to build systems that give clinicians the tools to do their job well. And that includes access to both FEES and video fluoroscopy. It includes adequate staffing, follow-up pathways, interdisciplinary care models, safe productivity requirements. If, I know I'm not going to be able to say no productivity requirements, it's safe ones, and research that measures patient-centered outcomes rather than only whether aspiration was observed or not. And I think we also need to give ourselves some grace as the evidence evolves. I think about this, 10 years of being, clinical practice. And my first year, I put patients on putting thick liquids, IDC-4, extremely thick liquids at the bedside, because that's what I was taught and that's what I knew. And, and it's one of those things that can be really hard to realize that a practice we used with good intentions at the time may not have served our patients the way that we had hoped they would. And so that is difficult because, clinicians, also researchers, but we are devoting our lives to helping. We want things to be better and we want to help people. But updating our practice still doesn't change our why of why we want to do it. It actually honors it. And I like talking about it this way. Again, I have my little symbols and analogies, but I talk about it with dysphagia research. I call it Marie Kondoing our dysphagia practice. And that's Marie Kondo is tidying up. And she talks about how you tidy up and and what brings you joy. And if something doesn't bring you joy, you thank it for its service and you set it aside. And I like to call it Marie Kondoing our dysphagia practice. We did the best we could with the information we had, and it brought us joy, it brought us good science. And then we have new information that might be better or, whatever else. We thank our old information and research for its service, and then we set it aside and we move forward with our new, maybe more rigorous science information. Because the future is not just new treatments, it's better decision-making, it's better systems, it's better access, and better alignment between our swallow physiology and our real patient outcomes. So I think that's a really important thing to think about. And I don't know why, I really like the idea of Marie Kondoing our dysphagia research.
No, that's wonderful. That's a really great analogy. And also it also puts us into the reality, we can't just learn all this research. I mean, it would be wonderful, but when it comes to actual implementation in everyday practice, I mean, obviously we want to become really good clinicians. We want to really implement them, but it's not easy. And as you mentioned, what we were as clinicians 10 years, 15 years down the line, or we were when we just got graduated and we started working versus what we are now, I think we ourselves have evolved. We read this and we're like, okay, let's try it out. And it worked. And I mean, our own research is our evidence-based practice that we work with our patients.
And even months ago, my practice has changed from months ago. And, there are still times that I look at things that I felt so strongly in, and I went to went to Dr. Steele when I was going to do my dissertation. I said, I'm going to prove that thickened liquids are, no.
No go.
That was my goal. And then as I learned more and read more research, and I realized, and I've definitely become, there is a time and a place, but we want to do it in a very mindful, comprehensive way, which is the better way to do it, really. Nothing is black and white, everything and light
Yes.
gray.
Yes, absolutely. Great. That's true. So what advice would you give to the newer SLPs who are interested in pursuing both acute care practice as well as research in dysphagia? Because, I really admire you for that. It's very rare to find speech language pathologists who are actually doing both.
Yeah, absolutely. Well, same with you. Same with you. So, yeah, so I think that, acute care dysphagia and dysphagia research are both just too complex to do well in isolation. They need each other. So, finding people who challenge your thinking and help refine your questions and model how to stay clinically grounded while doing rigorous science. That includes SLP mentors. And there are, phenomenal people within SLP, but also just in dysphagia and dysphagia research. It also includes physicians, nurses, respiratory therapy, dietitians, radiologists, implementation scientists, statistician, and our patient partners, keeping with our patients. And, another panel at DRS that Dr. Rogas Puglia did that, she and her lab coupled with this, I think it was the Department of African Studies at UW-Madison, to become culturally aware and understanding of a population, and then also understand then what are the actual, questions that they have about their health in this community. And I think that was such an important consideration there. And really, I feel like the best research questions often come from the space between disciplines and not just from one discipline or the other. From another standpoint of like both of these factors, I would tell newer SLPs and, dysphagia researchers to make sure and become medically fluent. And not because we're trying to be medical physicians here, but because swallowing decisions are medical decisions. You can't separate dysphagia from neurologic status or pulmonary reserve or cognition or infection risk, medication effects, these kinds of things. And our medical fluency is our patient advocacy. The more medically fluent you are, the less likely you are to reduce a complex patient to an oral intake label. That's a big thing with like, accepting risks and, things like that. And I've had, some people that I've spoken with that will say, oh, well, the patient knows that they're aspirating and they're choosing to eat and drink, so they need to be on comfort care measures and no escalation of care. And I used to think that, but as I've practiced more, I said, well, let me ask you this. Do we stop treating COPD exacerbations if the patient continues to smoke? And we do.
Lovely.
So we don't need to, we all do things that we're not supposed to do, or it's not the best thing for our health. So, understanding that and being medically fluent enough to provide that information while also supporting the complexities of the patient. And then also staying as curious as possible at the bedside. Asking these questions of what changed since yesterday, what information do I have, what information am I missing, what would imaging clarify, what is the risk of my recommendation, not just the benefit. And I actually, for my students, I like my graduate students that might come and do a clinical with me, I made these little detective sheets that I have them fill out when they're doing chart reviews on our consults. It might be a little bit juvenile, but I think it's fun and cute. So I have them write up the facts, and I have prompts, and it's like, what is in the patient's chart? It's like, build your evidence, what's in the patient's chart? What are their risk factors? And then I have like, interview the witnesses. What does nursing say about this patient? What do the other disciplines say is occurring? And then we build our case off of that information, and then what we observed at the bedside, and then hopefully also on swallowing imaging. But we're building our detective case because we are detectives of dysphagia. And so for the research side then too, I would tell, people trying to do this that to always be kind of aware of these tough clinical positions that we are put in and treat them as research questions. If a patient, if there's a patients that are being placed on an oral intake modification without imaging, that is a research question. If NPO recommendations are persisting without reassessment, that is a research question. If fees access depends on staffing or a day of the week, that is also a research question. It's a systems one. So really, if oral care is inconsistent or if G-tube decisions vary widely, follow-up breaks down after discharge, or these recommendations are not translating into real-world intake, those are research questions. It can really start with the moment that you realize the system is not working for these patients the way it should. And that's actually what made me end up pursuing a PhD, was that I really was having a hard time working within the confines of the system and knowing that what I am doing didn't always serve the patient as much as I tried. And so that was something that I wanted to then kind of build upon my experiences with that to answer some of these questions, that I've been seeing at the bedside. And, part of that too is encouraging newer clinicians to, become research, fluent, but to learn these methods gradually and intentionally on how to read literature and how to ask these answerable questions, how to look for bias, how to work with data, and how to translate clinical observations into feasible studies. Because genuinely, you can have a clinical question and translate that into a feasible study. You just need the supports to do that. You don't have to know everything at the beginning, but you do need humility and persistence and people around you who can help mentor you and help you grow. And the moment that you feel that you know enough, you really need to question yourself, because you will never know enough, and none of us will. There's I think it's a philosopher quote, but it's like, the only thing I know is that I know nothing, or something like that.
Yes.
And that's been so true. The more I have gotten into research, the more I'm like, the more questions I have, and the more I'm like, oh no, I don't know anything. I don't know anything about this, which of course, we know enough, but we're in a field where we have some incredible and phenomenal researchers and clinicians, and many of whom are more than happy to support and provide mentorship. And we have to learn from them, and we have to collaborate with them. But the last biggest thing out of everything is that always keep the patient at the center of everything you do. Food and drink are not just calories and liquid. They are culture, they are comfort, they are autonomy, they are identity, they are family, and they are dignity. Our job is not to prevent aspiration. It is to support airway protection, nutrition, hydration, rehabilitation, communication, and recovery, in a way that honors the patient. And that is also what should drive our research. Our best dysphagia clinicians and researchers stay close to the patient, close to the team, and close to that evidence and that evidence-based practice and literature.
I love it. That was one of the, I think it was like beautifully presented and clearly said, because yeah, as I always also feel that as a speech language pathologist, when you're doing assessments, you don't have to put patients all the time on a diet if they are not
Yeah,
safe. But
right.
little things, I mean, not little things, but things you do, like oral care, bringing up the interdisciplinary team together, or even having goals of care conversations, which
Yes.
would then trigger in terms of like, okay, let's do some pleasure feeds or things like that. It's basically, it's helping the patients. It's not going to create a more further problems or complications, but it's more helpful for
Yeah.
them. So I think I really like that bringing all of them together and then looking at what would be required, rather than just like, okay, no, I'm a speech language pathologist, I have to do bedside swallows
Right.
and then put them on diet because that is my goal.
Exactly. Well, and it's too like the idea that, the patient is more than that. And there's a book that it's a phenomenal read if people haven't read it, but it's called When Breath Becomes Air. And basically, it's a physician who is undergoing the dying process because he was my age, like, young in their 30s. And he unfortunately had, I believe it was lung cancer. And he talks about the dying process, but he talks about how you go from talking about someone breathing versus someone getting air, and how the
Mm.
air becomes clinical and sterile, but the breath is like the life, and like but it's,
Refreshing.
and yeah, and so remembering that these patients are dynamic, and it's not just air, it's not just liquid restrictions, it's not just these things.
Wonderful. I think I'm going to read that.
Oh
That's a
yeah, it's
good.
really good. I will say, it's so beautiful. I cried,
I'm sure.
understandably. But it's very beautiful. And I believe that he also was like a poet, or he was like a literature, or like a, literature major or something like that too. So he writes beautifully as well.
Wonderful. Nice. Okay. All on my list.
Yeah, yeah.
All right. Thank you so much, Dr. Crawford. This was such a beautiful, I would say I really enjoyed this conversation.
Thank you.
And
I did too.
thank you. And as I mentioned, I like it really comes from my heart for speech pathologists who are in clinical care, in clinical settings, as well as they are heavily research based, also heavily research based. But like, you're doing your little bits of what you
Yes.
can do outside of your work schedules, because
Yes.
that's intense enough.
Yeah.
So
And I
so
think that's, a thing. Everyone can be a researcher in this. And I know it sounds like, yeah, like, like not trying to be like a preschool, show, but it genuinely can be. It starts just with a clinical question and a research question, and then you can go from there and build it. It's not, you don't have to have a PhD to do it. You don't have to have an SLPD to do it. You have the question, and then you can be supported accordingly.
absolutely. And bring on the mentors.
Yes, yes, absolutely. Because man, are we so fortunate in our field with dysphagia researchers. I mean, gosh, even the other day, Dr. Laura Bajans, I had a complex patient case, and I came across an article from her, and I emailed her, and I was like, "Hey, I saw this article. I have this patient. What are your thoughts about this?" And she responded beautifully, gave me such a lovely response to that, and helped me. And it was really amazing. But like, that's the kind of field we're in. So take advantage of that, because, how many fields would have someone that, especially someone like her who's so decorated, in the field, and,
So,
has so many publications that just, oh, thank you so much for like emailing me. Let's chat about it. It's really just incredible. We're really fortunate.
we are, yeah. That's how my SLPD journey started.
Oh, that's so
I
great.
emailed, and yeah, it just begins from there.
Absolutely. And you've done a phenomenal job too. And I love how you're bringing this to the social media and, things like that too. I think that's really important, that, also too, remembering that there are also humans behind the research too.
They have done so much work, and I think everybody is so busy with it. And my only goal here is to, I think, just build awareness, more education,
Yeah.
and just discussions. You gain so much out of it.
I agree. 100%. 100%. Yeah, that's something I talk about at work too, at the hospital. Like, we we talk about our patients not in like a bad way. We talk about our patients in a, hey, I'm doing this. This is the thing. Is there anything else you would do with this? Like, or hey, would you mind taking this patient one time? I would love another set of eyes just to see if I'm missing something. Those kinds of things is, because we all can learn from each other.
Absolutely. And having that growth mentality, the growth mindset, I think
Yes.
that was I think I clearly remember I had my interview with for my SLPD with my program director, and I clearly remember Dr. Moore, Dr. Courtney Moore, and he was like, it's really important to have that growth mindset. And if you have that, I think everything else would fall in place. And I think that stood out. It just sat with me.
And it's
And
so true. You're
and it's
not a victim of your environment. You can grow in your environment.
yes. Yes. Once again, thank you again.
Thank you
And,
so much. It was great to
and
see you.
great to see you as well.
Okay, take
Okay.
care.
Bye.
Bye.